Okay. A very warm welcome to one and all in today's webinar on raising awareness on breast cancer, save the life of your loved one. October. This is the Breast Cancer Awareness Month, an annual campaign to increase awareness on breast cancer. We at RGU organizing the webinar on breast cancer awareness to show every woman that her life is important and to ensure that every woman has access to education, screening, treatment, support, and hope. I, Ms. Lipika Hajurika, on behalf of Royal School of Nursing and Royal School of Medical and Allied Sciences, would like to take this opportunity to welcome our esteemed speaker, Dr. R. Ravi Kannan, sir. We are also honored by our presence of our respected chairperson academics, Professor A.K. Buragahai, sir, Dean, Royal School of Nursing and Royal School of Medical and Allied Sciences, Professor Dr. Gitumani Kaur, madam, my colleagues, students, ladies and gentlemen, welcome to the webinar. Royal Global University is a leading university of Northeast India committed to provide unparalleled education to render holistic development of the students. It caters to 27 schools offering 130 plus courses. One of the strongest pillars of RGU is its highly qualified and well-experienced intellectual capital who also serve as a motivation catalyst for over 5,000 students. We at RGU strives for academic excellence through research-intensive and industry-oriented education instilled with a strong sense of becoming a global citizen. Ladies and gentlemen, I welcome everyone in this webinar, which has itself formed a part of long series of more than 350 webinars hosted by our university since the pandemic outbreak. But before starting this session, I would like to convey the information that our Honorable Vice Chancellor, Sir, Professor S.P. Singh, will be joining us a bit late as he is having class till then. Now, I would like to request Madam Professor Dr. Gitumani Kaur, Dean, Royal School of Nursing and Royal School of Medical and Allied Sciences, to kindly address the gathering. Over to you, ma'am. Kindly take over, ma'am. Madam, Professor Dr. Gitumani, ma'am. Ma'am, kindly take over.
Yeah. Sorry, there is some little bit. Good afternoon, sir. So, good afternoon, everybody. Today we are gathered here to discuss a very important topic, that is awareness on breast cancer. Save your loved ones. So, breast cancer, as we know, it is the second leading cause of death. So, and it is mainly two types, lobular and ductal. So the breast cancer, there are some risk factors like all male and female both can get. It's the might that only can get those. Then aging is, as we are going, age is going higher, then the older women are more prevalent. Then if I have a family member, my mother, my sister, someone has already had breast cancer, then my risk of developing breast cancer is higher. And the woman who is having oral contraceptives, for them also prevalence of breast cancer is higher, as well as the people who is not breastfeeding, they are prone for breast cancer. Such a way, the girls who are getting married after 30, they were more prone for breast cancer, as well as the girls who has achieved and menarche at an early age and the menopause at the later age, those were for those women also have chances of developing breast cancer. So as you know, the chances of breast cancer, and it is very important to prevent it. As we have come to know different risk factors, if we can protect these risk factors, we can save save the life of our loved ones. And another things I would like to share, breast screening is very important. So if we can detect at the earliest at the stage 1, then 90% of the people can get survival rate up to 10 years. So as the survival rate is very high if we can detect it at the early stage. So the key of that early detection, it is in every woman's hand. So every woman and girl, if they practice breast self examination, so they can look after their own breast to find out is there any abnormality. So after every menstruation, the menstruating girls or menstruating women, they can look after, they can do breast self examination after 6 to 7 days of menstruation, and the pregnant lady, they can choose a date, as well as menopausal woman, same date of every month. So they should palpate their breast, they should stand in front of the mirror to look at the size and shape of their breast, and they have to palpate in a circular motion every space of their breast as well as around the armpit. So by that they are the person who can detect at early if there is any changes happening in their breast. So with this I conclude my message is every woman should be practicing breast self examination, although we tend to forget. That's why if we make it a schedule or routine, definitely it will become our habit and it will become our behavior, so we'll not be forgetting. So as the rate is very high, it is the second leading cause of death, so we have to be very careful. So on this special occasion, we have invited Dr. Ravi Kannan, Padma Shri Awardee and Director of Cancer Care Institute, who is going to enlighten us with his knowledge and experience. And we are going to be with him next 1 hour. Thank you, Lipika. Over to you.
Thank you, madam, for your brief introductory note and also showing us the importance of breast self-examination. It is seen that breast cancer rates are increasing in nearly every region globally, and according to studies, early detection of breast cancer can increase the survival rate of the patient. To speak more about breast cancer, we have Dr. R. Ravi Kannan sir with us. But before I move on to Dr. R. Ravi Kannan sir, I would like to request our Honorable Vice Chancellor, Professor S.P. Singh sir, to put forward his initial remarks. Well, Professor S.P. Singh sir is a very well-known personality in the field of academics and administration who I believe needs no introduction. But for the participants who have joined us for the very first time, I must tell you that Professor S.P. Singh sir has been associated with the Royal Group from its inception in 2009 as the founder director of the institution. He further moved to Amity Education Group in 2013 and joined as the Senior Vice President Academic of the group and was responsible for functioning of 6 Amity campuses situated in different parts of the country and abroad. He also served as the founder Vice Chancellor of Amity University, Chhattisgarh for almost 2 years before joining the Assam Royal Global University in November 2016 as the founder Vice Chancellor. With the vision and hard work of Professor Singh, the university has been ranked the #1 private university of Assam by Education World within a span of just 3 years. A geologist, MBA, and a law graduate with PhD in strategic management, Professor Singh sir is also an ardent baseball player and has been actively involved in various social and cultural activities since his university days. Sir, I would humbly request to forward your initial remarks. Over to you, sir.
Thank you. Thank you so much, Ms. Lipika. So kind of you. You have given a very elaborated uh, introduction of mine. Basically, for Dr. Kannan, I'm only a teacher and I'm into this profession by choice. And I'm trying my level best to do something in this part of the country after serving for almost 20 years in other part of the country. So I joined Royal Group Institution in 2009 and I was reading your profile and you probably shifted to Assam in 2007. So you almost have covered 13 years, but your journey is a very coveted journey. You have done a great thing for Barak Valley, for cancer patient, bringing them 28% people were coming to the hospitals because of their poor conditions and other things. You could bring that to 70%, and that is a great achievement. And you have performed 70,000, cancer patients treatment, and you are basically a surgical oncologist. So it's great, great honor for me and for Royal Global University to host you today for today's webinar on this, because this is really inspiring, motivating for anyone who is a doctor. I am from a biology background. I did my class 12th with biology, but never thought of becoming a doctor. But almost all my friends who were with me in my school, that is in Lucknow, from Colvin Talukedar's College, Lucknow. I think almost all of them are doctors, and they are not here. They are working so many places in the world, and including so many hospitals in the country, which are providing free, medical facilities for heart surgery. And Bharat Dubey is one of them, and many of them otherwise, to people of this stature, which who could not afford any kind of medical treatment. So I think Dr. Kannan, for Barak Valley, for Assam, you are a role model, you are Padam Shri, you have been coveted, you are well deserved. For that, I think many of us will get motivated by your deliberation today. As far as breast cancer is concerned, I have only little experience about that, because as a family man, I have to take my people at my home for different kind of mammography on the regular basis. It has been told that it should be done preferably every year, every second year, if not every year. And also once the, as Gitumani Madam has said, that there are many conditions that is starting from, puberty to menstruation and all other things, late childbirth and all other things, they are maybe responsible for some kind of, that may be hereditary also, breast cancer. But I remember, and I will recall that in my home in Lucknow, where I used to live throughout my life for 40 years almost. I remember when I was in class 11th or 12th, one of my very close friend, I will not take the name deliberately, next door neighbor of mine also, Mr. Maheshwari, his mother was being identified with, uh, tested with breast cancer. And I remember auntie, I used to talk to him, and we were very, very, we thought cancer at that point of time, I'm talking about 1984, 85. It was something which people said, once cancer is there, you're gone. You're gone maybe either in 6 months or 1 year or 2 year maximum. But I say, that time also the doctors have done the surgery to her, and she could survive for almost, I think, 20 years after that. So that was something which I came to know. If the cancer has been detected at the right time, this can be cured. If not been cured, that can be surgically operated, and people can save life and can live for, well, 15, 20, 30, 40 years. So that is my understanding. I may be wrong. I may be corrected by Dr. Kannan, but this is my experience. And therefore, since then, I was very, very, I would say, very, very conscious about these issues around me. And I have taken due care of my family to the best possible way. And people around me also, whenever I get a chance, I give them some kind of advice, if at all possible. And we all are people who know about it, but there are many, many people in the country and the world who do not know about it. I would earnestly request Gitumani Madam and Lipika Madam, they are regularly doing it, that they go to the community around university. We have adopted 5 villages, and you should please take up a charge and please train people to teach, or maybe to inform people in the surrounding area of the university about the breast cancer awareness. So this is what my side is. Over to you, Lipika, and I'm very eager to hear Dr. Kannan. Thank you so much.
Thank you so much, sir, and thank you for the remarks. Moving on, we have amongst us a very renowned personality, Dr. R. Ravi Kannan, sir. Sir is the surgical oncologist from Chennai who has treated over 70,000 cancer patients free of cost and has been conferred with the Padma Shri. Dr. Kannan is one of the 118 recipient of India's 4th highest civilian honor for 2020. Also known Silchar's savior, Dr. Kannan quit his job from the Adyar Cancer Institute after 15 years of practice in Chennai and shifted to Assam with family in 2007 to make healthcare accessible in the Barak Valley. Dr. Kannan sir is presently the director of Cachar Cancer Hospital and Research Center in Silchar. that caters to people from all socioeconomic backgrounds. Besides providing free treatment to cancer patients, the hospital also provides accommodation, food, and employment. It is my privilege to welcome you, sir, and we also look forward to hear from you. Sir, kindly take over.
Thank you, Professor Singh, Professor Hazarika, Professor Gitumuni, Mrs. Lipika Hazarika, the Royal University, Royal Global University. I'd like to thank all of you for this opportunity. I will keep my video switched off because my bandwidth is very poor. Thank you. So, this is Breast Cancer Awareness Month. All of us know that breast cancer is the commonest cancer amongst urban women in India and the second commonest cancer amongst all women in the country. We see more than 1.6 lakh new breast cancers every year, and at any given point of time, there will be 5 to 6 lakh patients living with breast cancer at any point of time. 1 in 28 women in India will develop breast cancer. In urban areas, it is 1 in 22 women who will develop breast cancer. Unfortunately, a majority of our women present with advanced disease that results in very poor survivals. Early stage breast cancer cure rates are upwards of 90%, whereas when we have metastatic disease, survival is not even 20%. Our fear should not be the fear of breast cancer, but of delay in diagnosing breast cancer. We must make every attempt to encourage women to come forward for early diagnosis. Quickly, many of you probably know this. The breast is a gland which is essentially meant for lactation to feed newborn infants. And it consists of glands which secrete milk and a lot of stroma, which is fat and other connective tissue. The glands are all like clusters of grapes, you know, each grape, assuming each grape is an alveolus. Alveolus is nothing but a collection of glands. Each cell is a gland. Each cell will produce secretions, which it will release into the tube, the duct of the gland. Many of these ducts join together to form larger ducts, which ultimately form even larger. And finally, there are about 15 lactiferal ducts, which open into the nipple. Now, breast cancer can occur in the glands, in the muscle myoepithelial cells around the glands, and in the stroma, in the fat and connective tissue around the. So the commonest type of cancers are those that arise in the ducts, and these are called duct cancers. Some of them can arise in the lobules itself, and those are called lobular cancers. Duct cancers which occur in the nipple, you know, have a peculiar form that is called Paget's disease. That is a form of duct cancer. And then we have other cancers, you know, which can occur in the fat, in the stroma, the phyllodes tumor, you know, whole lot of. There are also a lot of benign tumors. Most breast lumps are not cancers. Most breast lumps are benign. Now, the cancer grows initially within the lumen, and then once the cancer breaches the basement membrane, all the duct cells, you know, that secrete milk are sitting on a floor called the basement membrane. And so, and the lining is only one cell thick. So if you look at these ducts, you know, each gland has only one cell lining the lumen. If you have many cells, you know, then the secretions cannot get into the lumen. So there is one cell each one. And so when there is malignancy, what happens? It becomes multi-layered, and finally at some point of time, it will breach the basement membrane, and then it is free to spread to other parts of the gland. A cancer which is limited by the basement membrane is called an in situ cancer, a stage 0 cancer. And this cancer cannot metastasize, cannot spread to other parts of the body. And the cure rates of this cancer are 100%. So breast factor has certain risk factors. What are the risk factors? Who are the people who can get breast cancer? The highest risk is for any, there are factors which can be controlled and there are factors which cannot be controlled. Of the factors that cannot be controlled, the most important factor is being a woman. If you are a woman, you run the risk of a breast cancer. Men have account for less than 1% of breast cancers. If you have 100 women with breast cancer, you might find one man with a breast cancer. As the woman ages, the risk of cancer increases. Cancer is a disease of aging mostly, and older the age, higher is the risk of cancer. Certain races are at high risk for breast cancer. Fortunately, Indians are not amongst those races that have a higher risk of cancer. History of breast disease, especially some form of benign breast disease, increases the risk of developing breast cancer. Any family history, we will talk about family history in a little while. Family history of breast cancer increases the risk of breast cancer. Menstrual history, breast cancer occurs because of the influence of the female hormone called estrogen. Estrogen secretion starts somewhere around menarche and goes on continuously till menopause. So, a few years ago, 30, 40 years ago, our girls, our young children used to start menstruating, used to establish menarche around the age of 15. Now with urbanization, changing lifestyle, the age of menarche is gradually coming down. Now girls as young as 8 or 9 years start to menstruate. And so the period of estrogen exposure is progressively widening. And that early menarche and late menopause is one of the risk factors for developing breast cancer. And then, of course, there are genes about which we will talk again. Factors that can be controlled. Our diet. Obese women have a higher risk of breast cancer. Women who are overweight, women whose diet has an excess of fat. So diet always goes hand in glove with exercise, and diet and exercise are incriminated in a wide variety of cancers and non-cancer diseases, diabetes, hypertension, cardiac problems, stroke. All these go hand in glove. The factors that cause cancers very often cause diseases other than cancers also, and it is not uncommon for a woman with a breast cancer to have diabetes, to have hypertension, to have other comorbid illnesses. Women who consume alcohol, women who smoke, women whose physical activity is limited. Now reproductive history, again, when during pregnancy, a prolonged period where there is diminished estrogen secretion, and therefore women who are nulliparous, who never become pregnant, certain communities like nuns don't marry and don't have children, and the incidence of breast cancer is higher amongst nulliparous women. Women who have late pregnancy similarly have a higher history of breast cancer. Women who don't breastfeed their babies, the risk of breast cancer increases. And then women who are on hormone replacement therapy for a variety of reasons also run the risk of having breast cancers. Now, what are the symptoms and signs of symptoms are problems that the patient will present with, whereas signs are features that the doctor or the nurse who's examining will detect. So any painless lump, any new unexplained painless lump or thickening in the breast or armpit could indicate a breast cancer. Any nipple discharge, especially if it is blood stain, could indicate nipple discharge, could indicate breast cancer. Any crusting or scaling or eczema-like lesion on the nipple, indrawing of the nipple normally protrudes outwards. Suppose for some unexplained reason the nipple gets indrawn, could be a indicator of breast cancer. Any change in the shape, size, curvature of the breast, puckering, scaling, ulceration, redness of the breast skin, and any newly discovered area in the breast that appears different from other areas of the breast or other from the opposite breast needs prompt medical attention. Having said that, again, I want to re-emphasize that most breast lumps are benign. They have fibroadenoma, fibrocystic disease, abscess, galactosine, but then no breast lump should be declared benign unless a doctor has seen and evaluated them. We must not say, oh, this is nothing, it's okay. Everything that is abnormal in the breast or any other part of the body must be seen by a doctor, evaluated, and then only we should say, okay, this may not be cancer. How do we diagnose breast cancer? A clinical examination is mandatory. The breast, the axilla, the general physical examination must be completed. Sometimes we may ask for an ultrasound of the breast and the armpits. A mammography is usually indicated where the breast cancer is early. When we have an advanced breast cancer, mammography has a very little role. MRI has indication in very specific situations. The most important thing to establish diagnosis is to examine the cells using a fine needle aspiration. We have a cytology preparation where individual cells are seen, or we can take a biopsy, a variety of biopsies. We can take a needle biopsy, we can make a cut and take a biopsy, we can remove a lymph node for biopsy. Biopsy, you see histological preparations which look like this. The parameters used to diagnose the cancer are slightly different in both situations. In the biopsy, we would look for the grade of the tumor. Grade meaning how aggressive it looks under the microscope. We would look for a variety of receptors, the estrogen receptor, the progesterone receptor, the HER2/neu, the Ki67. These indicate this would indicate what sort of treatment to offer the patient. Ki67 will also will go hand in glove with the grade of the tumor and will tell us how aggressive the cancer could be. And then now there are more and more genetic tests coming in. We will talk about these again in a little while. These are immunohistochemistry preparations for ER and PR, and these are these are negative and these are positive smears. Now, once a diagnosis is made, we have to stage the cancer, how extensive it is. Histopathology or cytology is the only way to diagnose the cancer. Everything else, the CT, the X-ray, the ultrasound, the bone scan, all do not diagnose the cancer. They help detect how extensive the cancer is. X-ray chest, when we have an X-ray chest which shows nodules like this, it is obviously a stage 4 cancer. When we have a bone, the skeletal X-ray which shows a large destructive lesion in the bone, it is metastatic cancer. CT scans of the chest and abdomen showing liver deposits. We can have sometimes chest wall deposits or internal mammary chain nodes. Bone scans will show how extensively the skeleton, if it is involved, is affected. PET CTs are now coming into vogue. The role of PET CT is evolving. And as of now, PET CT is indicated whenever the conventional tests are equivocal. Could be, may not be. Sometimes when we want to do a staging evaluation, we may not do any other test other than just a PET CT, which will scan the entire body, excepting for the brain. Now, how do we, with using all these investigations, how do we stage the disease? We use what is called a TNM staging. We have some tumor characteristics, and then all tumors initially spread to the regional lymph nodes. So in the case of the breast, it will spread to glands in the armpit, in the axilla. So that is the nodal staging. And then M is the presence or absence of metastasis in other parts of the body, in the lung, in the brain, in the bone, in the liver, wherever else, okay? And so a combination of the T. So the T is divided into T1, T2, T3, T4, and N is divided into N1, N2, N3, and M is divided into M0 and M1. And a combination will give us a stage. So crudely speaking, T0 is a situation where the cancer, remember I told you about the in situ cancer, where the cancer is not capable of spreading, is a stage 0 cancer. A stage 1 cancer is that cancer which is very small and is limited only to the breast. Any cancer which is more than 2 centimeters or has developed lymph nodes in the axilla is stage 2. Any cancer which is more than 5 centimeters or has lymph nodes in the axilla is stage 3. And stage 4 cancer is that cancer which has spread to distant parts of the body. Now, treatment depends upon the stage of the disease. But the key word all of us today must remember is, just because the patient comes to Ravi Kannan operates. Just the patient goes to a radiation oncologist, he gives radiation. Patient goes to the medical oncologist, he gives chemotherapy. That is not the way cancer treatment works. Cancer treatment always is multimodality treatment, and surgery, radiation, chemotherapy, genetics, pathology, radiology, all specialists have to sit together, and every single patient must have advice from every one of these specialists. And cancer treatment will be most optimum when treatment is truly multimodal. So where the discussion is when we have to talk of sequencing, whether we do surgery first or radiation first or chemotherapy, what is to be done first, what is to be done next. Sometimes we may give chemotherapy and radiation together. So this sequencing is what the discussion all is about. When we say it is an early breast cancer, we mean any cancer which is stage 1 or stage 2. And in these situations, very often surgery may be the first treatment, followed by adjuvant chemotherapy. Any chemotherapy delivered after surgery is called adjuvant chemotherapy. Any chemotherapy delivered before surgery is called neoadjuvant chemotherapy. And so we would give chemotherapy, and then we would give radiation therapy. And then depending on the markers, remember we spoke about ERPR, we may use hormone therapy, or sometimes depending upon the genetics, we may use targeted therapy. However, if it is a locally advanced breast cancer where primarily surgery is not possible, we would use chemotherapy first and then consider surgery. Sometimes we may give chemotherapy and radiation and then consider surgery, and then follow up with hormone therapy and or targeted therapy. When the cancer is widespread, very rarely surgery is done. Surgery is done only when there is a fracture and we want to fix the bone, or sometimes occasionally when there's a very large fungating tumor and we want to improve the patient's quality of life. Often treatment consists of chemotherapy, hormone therapy, radiation therapy, and targeted therapy. Now, surgery for breast cancer, all breast cancers do not need a mastectomy. That is what I want to tell you today. Whenever the tumor is small, we can remove the lump and conserve the breast. And so women need not be concerned that if a cancer is diagnosed, the breast will be amputated. Mastectomy is reserved for usually larger tumors, small tumors, or a tumor in a larger breast. We can just remove the tumor and preserve the breast with excellent cosmesis. Surgery consists of two parts. One is surgery for the lump in the breast, which we can either do a lumpectomy or do a mastectomy, and for glands in the armpit. So sometimes we may remove only what is called a sentinel lymph node, or the first lymph node to which the cancer spreads. Sometimes we may remove some nodes in the armpit, and sometimes we remove all the nodes in the armpit, depending on the number of parameters. Now, after surgery, the post-surgical care is very, very important, and very often a physiotherapist, a psychologist, many people are involved at this point of time. We have to ensure that the patient has good shoulder exercises, because often after breast surgery, shoulders become stiff. Now, when we remove glands in the armpit, the drainage of fluid from the hands is impaired. And so sometimes the hands will swell up grotesquely, what is called as lymphedema. And lymphedema can be prevented with proper, immediate post-operative attention, including massage, including wearing stockings like this, and through a variety of exercises. The chest wall and the breast must be taken care of. We must if the breast is preserved, if there's a breast conservation procedure, which happens more than 50% of the time today, the breast needs to be supported to reduce swelling and pain. When a breast amputation has been done, when a total mastectomy has been done, it is very important to advise some form of prosthesis which can be mounted on the brassiere. Depending on the cup size, we have small, medium, large prosthesis to give symmetry to the appearance, and more importantly, to provide balance to the shoulders. If there is a breast on one side and the breast on the other side is removed, the shoulder on the side where the breast is remaining will tend to droop. And to prevent that, we need to provide a prosthesis to ensure that the woman has a good posture. Now, remember, women who undergo mastectomy, who are very concerned about their appearance, can have breast reconstruction done. And a variety of procedures can be done. We can take tissue from other parts of the body, or we can put prosthesis, or sometimes we can use a mixture of methods. But the main thing is breast reconstruction is possible and can provide immense comfort and confidence to a number of women. The reconstruction can happen immediately after surgery, or it can happen at a point distant from the surgery. Now, after surgery, usually we will offer the patient systemic treatment, which means chemotherapy. Now, systemic treatment, chemotherapy can be a single or a combination of drugs. We won't go into detail, but there are a number of drugs, anthracyclines, antimetabolites, taxanes, platinum compounds. Variety of drugs are available. Now, some of them have toxicity, but remember, all chemotherapy toxicity is temporary and can be handled very well with proper care and anticipation. Then, depending on the hormone receptor status and whether the woman is premenopausal or postmenopausal, a variety of hormone therapies can be offered, will be offered, in fact. And then, if the woman expresses some specific genetic characteristics like HER2 positivity, we would offer them targeted therapy. And in some metastatic situations, we will offer them immunotherapy, which is an up and evolving specialty at the moment. Many patients will also require radiation therapy following surgery for breast cancer. If the breast has been removed, if a mastectomy has been done, the radiation is given to the chest wall in certain situations. If the breast has been preserved, in that case, all patients will require radiation therapy to the breast, to the remaining breast. Radiation therapy can be delivered from an external source, which is called teletherapy, or from radiation sources implanted within the breast, which is called brachytherapy. Now, not all patients require chemotherapy after surgery for early breast cancer. All patients with advanced breast cancer require chemotherapy. But for early breast cancer, individuals who have node positive disease, who have HER2 positive disease, those who are premenopausal, those who are high grade, will usually receive some form of chemotherapy. But those who have very small tumors, who have ER/PR positive tumors, HER2 negative, postmenopausal, low grade tumors, many of them don't require chemotherapy, and chemotherapy will induce a lot of undue morbidity. So in order to decide, see, we are understanding more about all of this as the years go by. Now, to help doctors and patients decide who should get chemotherapy and who should not get chemotherapy, now there are a number of online prediction tools, where you just feed in the data and it will come out and tell you this individual will do well with chemotherapy, this individual does not require chemotherapy. And there are several online prediction tools available. But what is even more important and even more accurate are the large number of genomic tests that are now coming up. There is the Oncotype DX, which is actually coming into the staging systems of breast cancer. And then there is the Mama Print, and there is breast cancer. Several of them are there, for which the tissue is analyzed for a number of genes in the tissue that are upregulated or downregulated. And using, so if you look at the Oncotype DX, it uses 12 gene assay. The Mama Print looks at 70 genes. The Prosigna analyzes 58. So different tools use different sets of genes, and many of them are comparable. One of the most popular ones used today is the Oncotype DX. Remember, all of this is only in a situation where we think the patient may not require chemotherapy. Most of our patients who have advanced disease will all require chemotherapy during the initial part of treatment. Now, I mentioned family history as a risk factor for development of breast cancer. Now, what do we understand by family history? Family history is one first degree relative who has advanced disease, or second degree relative who has advanced disease, or second degree relative with ovarian, say breast cancer, ovarian cancer, endometrial, that is cancer of the body of the uterus, colon cancer, pancreatic cancer, they all have many common etiologies. So any first degree relative, then ovarian cancer, any first degree relative with a sarcoma under the age of 40, with some brain tumors, all these increase the relative risk of breast cancer in their first degree relatives. Now, And so women who have a family history, specific family histories, may elect to go and get themselves screened more often. Now, based on these histories, there are also tools available which help breast cancer risk assessment. The most commonly used tools are the Gale model and the CLOS model. And then now we have the BCRAT tools. You know, there are several other tools where you feed in the data of your family history and you get a sense of going on development of artificial intelligence. Now, what we must understand is women who have a family history or an assessed high risk of breast cancer need to go and get themselves screened for breast cancer. We will talk about screening in the next slide. Now, there is another thing called genetic testing for breast cancer to look for genes which increase the risk of breast cancer. The most common genes are the BRCA genes, you know, BRCA1 and BRCA2. But there are also other genes, you know, the P53, P10. You know, there are other genes which may increase the risk of breast cancer. Now, breast cancer gene testing is not recommended across the board for all women. It is not even recommended for women with high risk breast cancer. Some women who develop breast cancer may develop BRCA1 if they are at high risk. Because why we are not recommending genetic screening for all women across the board is because we don't know what to do with all the information that we get. We really don't have enough knowledge of how to deal with all the abnormalities that we will pick up. Now, screening for breast cancer is another. Any woman with a family history of breast cancer needs to be screened for breast cancer. Government of India guidelines say that all women over the age of 30 years need to be screened. Now, screening can be done through breast self-examination, can be done through clinical breast examination, can be done using a mammogram, and in special situations, an MRI can be used for screening. Now, breast self-examination, we will talk about that in a little in the next slide. Breast self-examination should be carried out by all women over the age of 20. Now, breast self-examination itself is in a very big question mark, in a very big discussion, because there are studies from the West which have shown that breast self-examination does not help. It actually reduces survival. But those studies have compared breast self-examination with mammography, which is universally available in the West. In a country like ours, mammography screening is simply not possible for across everybody. We have too many women, we have too few mammograms, we have too few radiologists to interpret the mammogram, and mammograms are expensive. And whether mammograms actually improve outcomes is also a very big question mark. And so for India, mammographic screening of the general population is at the moment not feasible. Now, in a situation like this, see, the average size of the breast cancer that I see in my OPD is 10 centimeters. A woman with a 10 centimeter sized lump has a 40% chance of being a 10-year survival. A woman with a 2 centimeter lump has a 90% chance of being a 10-year survival. And breast is an organ that the woman feels every day while bathing, and a small 2 centimeter sized lump also will slip under the examining finger while bathing. And so if women can be taught to examine their breast properly, systematically, and instead of 10 centimeter lumps, they come with 2 centimeter lumps, I cannot understand why somebody would say that breast self-examination is useless. For a country like ours, breast self-examination is very, very, very important. Now, clinical breast examination is a situation where a doctor or a nurse examines the breast, and that is best reserved for women over the age of 30 who go to the hospital for other reasons, and for all women with breast symptoms. They have pain, they have discharge, they have heavy, whatever breast symptoms, that woman must be examined by a qualified doctor or a nurse and appropriately evaluated and advised. Mammographic screening is available for women over the age of 50 only. In younger women, where there are a lot of glands, the breast is very dense, and mammographic screening depends upon the contrast between the amount of fat and the gland. The cancer begins in the glands and the ducts, but the fat provides the contrast. And so if you have a breast where there are only glands and very little fat, the mammogram will all be white, and you'll be wasting the imaging. And therefore, mammographic screening is recommended only for women over the age of 50. Now, how is breast self-examination done? It must be done on the
Excuse me,
day.
sir.
Yes.
Sir, sorry for the interruption. Sir, actually, we are having some time constraint.
Okay.
So, sir, you have to shorten your
Yeah,
presentation.
no
Very
problem.
sorry, sir.
No problem. So I'm almost done. So breast self-examination has to be practiced by all women starting the age of 20. Every month, the day the menstrual cycle ceases, the breast has to be examined in a sitting posture and in a lying posture. You can use a variety of examination techniques. Now, mammography, just to give you an idea, breast self-examination detects the size of this size, and mammographic examination will pick up much, much smaller size tumors. And thank you very much. I'm done.
Okay, thank you so much, sir, for enlightening us with your valuable knowledge and also for beautifully describing about the breast cancer, like what are the risk factors, what are the factors that we can control and we can treat it by early detection, and also for showing us the importance of breast self-examination. So it was mean a lot for us. Sir, there are a few queries that has been popped up in the chat box. I would like to bring up, sir. There was a question like post-operative mastectomy, when physiotherapy should actually start.
So physiotherapy should start as early as possible after surgery, preferably on the second or the third day itself. Simple exercises and gradually build up. Earlier you start physiotherapy, better will be the shoulder function and lesser will be the size of the incidence of lymphedema.
Okay, sir. Thank you, sir. So there is another question. In which type of breast surgery lymphedema is more common?
So lymphedema will happen only when the axillary lymph nodes are removed. And that is why, people are trying to carry out surgery where they do not have to remove axillary nodes if it is not required. The whole concept of sentinel lymph node biopsy or axillary lymph node sampling is because of the incidence of lymphedema. Lymphedema will occur in about 10-12% of people who undergo axillary surgery, especially if radiation therapy is also required subsequently. So if the
Okay, sir.
axilla is not operated upon, lymphedema will not happen. Lymphedema can happen if there is cancer in the axillary lymph nodes, which will choke off the lymphatics.
Okay, sir. So there are two questions that has been brought up by our students. Will the breast cancer treatment affect the women's ability to have a baby?
So we very strongly recommend that the woman does not conceive for 2 years after chemotherapy has been concluded, because chemotherapy will affect all rapidly growing cells, and the oocytes are also cells on which the chemotherapy could have acted and induced genetic changes. But following after 2 years, the woman is free to have a baby. Breast
Okay.
cancer treatment will not make her infertile.
Okay, sir. So there is the last question. What are the potential side effects of breast cancer surgery?
So breast cancer surgery can cause some shoulder dysfunction, can cause lymphedema, can cause edema of the breast. Sometimes patients will have tingling and because of nerve entrapment. But for the most part, breast cancer surgery is safe and generally without major complications. Radiation therapy, on the other hand, could have some more complications, and chemotherapy, has the largest number of complications. But the good thing about chemotherapy complications, all of them are transient. Hair loss, mucositis, fall in blood counts, nausea, vomiting, diarrhea, all of them are purely temporary.
Okay. So I will take out the last question. There are so many questions that has been coming up now, but sorry participants, I won't be able to take answer because we have time constraint. So the last question, sir, like, is gene therapy possible for preventing breast cancer?
No, gene therapy as of now has not developed to the stage where we can prevent any cancer.
Thank you so much, sir, for answering all the queries. As we have come to the end of the webinar, I would like to take the opportunity to thank Dr. R. Ravi Kannan, sir, for devoting your time to us despite of your busy schedule. Thank you so much, sir. I would like to thank Professor Dr. Gitumani Kaur for your constant guidance in conducting the webinar. I would also like to thank our Honorable Vice Chancellor, sir, Professor S.P. Singh,